Hello, my name is Leo. I'm an intensive care doctor working in the UK. Hope you're well. In this video, I'd like to discuss how to assess the GCS. All of you guys know how to assess the GCS generally, so I will focus a bit more on some points that you might not know. The Glasgow Coma scale, GCS, was developed by two neurosurgeons from Glasgow, and it remains the most widely used coma assessment scale. It is used to assess the level of consciousness in patients by assessing the eye, verbal, and motor response to verbal commands or pressure stimuli. The maximum score is 15, and the minimum score is 3. It is important to assess each component of the scale and record the three components separately rather than the total score. For example, instead of just GCS 9, we should break it down to E3, M4, V2. Patients are frequently referred to intensive care unit for low GCS with or without airway concern. Occasionally, there could be some discrepancies between the GCS scored by referral team and the GCS scored by ICU team. As intensivists, we tend to give more intense verbal commands and pressure stimuli. However, we always need to bear in mind to minimize noxious stimuli whenever possible to avoid unnecessary patient suffering. Therefore, nowadays, we use the term pressure stimulus instead of painful stimulus. When we give verbal commands, we are inclined to get close to patients and use high volume and tone of voice. It means that we may need to shout at the patients, especially when the environment is noisy or when the patients have hearing impairment. We can call out the names and ask to follow simple commands such as to open their eyes, to stick out their tongue, or to squeeze our fingers. We can also ask simple questions, for example, if they have any pain or if they know where they are, and observe the response whether they nod or shake their head. In patients who are not obeying voice commands, we need to stimulate them with pressure. The actual recommended noxious stimuli, which are the least harmful, especially if repeated assessment is required, are squeezing the trapezius muscle, pressure to supraorbital notch, and lifting up the temporomandibular joints, which is performing a jaw thrust. It might be necessary to increase the intensity of the pressure up to 10 seconds until patient's response or maximum stimulus is applied. We should not put pressure to the supraorbital notch of the patient with facial injuries. Rubbing the sternum is not recommended at all because it can cause sternal bruising. Also, pressure to the nail beds is not popular anymore as this can evoke spinal reflexes. Thus, the response to such stimulus may not demonstrate the genuine brain function and may be confusing during the assessment. Now, as we understand how to give proper verbal and pressure stimuli, let's talk about how to score patients' responses. In eye component, if the patient can open their eyes spontaneously before any stimulus, the score is 4. If they open their eyes after spoken or shouted request, it is 3. And after pressure stimuli, it is 2. If there is no response whatsoever, then the score is 1. At the same time, we can observe verbal and motor responses of the patient. If the patient is orientated well by providing correct time, place, and person, is V5. The patient is communicating coherently, however, confused with poor orientation, then is 4. If the patient cannot verbalize fluently, but only single comprehensible words, the score is 3. We give the score 2 when the patient is making sound like moaning or groaning without any recognizable words. If there is no audible response, then it's V1. The motor response is mainly observed in upper limbs, so we should expose them and also make them free from restrictions during the assessment so that we could see them properly, and also give patient the best chance to achieve the highest score. Moreover, the M score plays an essential role in assessing and prognosticating patients in coma with severe traumatic brain injury. If the patient is obeying two simple commands, M6 it is. As we all know, if the patient can localize the pressure stimulus, it is M5. If they have normal flexion, M4, abnormal flexion, M3, extension, M2, and if there is no visible movement at all, then it's M1. Here, I would like to point out why squeezing the trapezius muscle or pressure to the supraorbital notch is more appropriate than pressure to the fingertip. For the patient to score M5 by localizing the pressure stimulus, they need to be reasonably strong enough to bring their hand above the clavicle to move the pressure stimulus away from their neck or head. If we give pressure stimulus to the nail bed, they could just shake it off. Hence, the response could be difficult to interpret. Besides, by squeezing the trapezius muscle or pressure to the supraorbital notch, we can assess whether the patient could bend their arm and elbow even if they're not strong enough to lift their hand up to the shoulder. If they could bend their elbow rapidly with arm away from the body, it is regarded as normal flexion. They are bending their elbow, however, if it is a slow movement with their arm across the chest, forearm is rotated with thumb clenched, then it is abnormal flexion, which was formerly called decortication, that could indicate upper midbrain injury. Arm extension was previously known as decelerate posture, and it could reflect lower midbrain or pontine injury. While assessing the motor response, we should carefully note if it's purposeful or non-purposeful spontaneous movement, or if it is symmetrical or asymmetrical movement. Deep tendon reflexes and extensor plantar responses should be done in case of asymmetrical motor findings, which could be suggestive of lateralization signs. Sometimes, the patient may respond differently in upper limbs, for example M2 on the right side and M3 on the left. Then, we should take the highest response and score M3. Fundamentally, the GCS is quite reliable, reproducible, and widely used by clinicians. Even so, there are some limitations. We cannot score the GCS in patients who are struggling to open their eyes due to pathologies, for instance eye injury or swelling, mechanically ventilated patients with tracheal intubation or tracheostomy, patients with language barrier, learning difficulty, hearing loss, or dysphasia, patients who are under sedation or paralysis, who are hemiplegic, or who have spinal cord lesions with quadri or paraplegia. We should record NT, which means not tested, if we cannot assess the particular component of the GCS. Furthermore, GCS lacks assessment of important elements of coma assessment in ICU patients, such as testing brainstem reflexes, respiratory pattern, and behavioral assessment. We can use full outline of unresponsiveness score 4 or the coma recovery scale as an alternative. I'll make another video about those scoring systems to discuss the topic coma and disorders of consciousness. That's it for me in this video. Hope you learned something new. If you do, please share with your friends and colleagues. I'll see you in the next video. Take care.